Well, if there's a television feed that people want to watch, I'll understand that. All right, well, thank you all for coming for our little state of Massachusetts and maybe for the country as well. This is an important day as well. So first I'd like to call the group to order. I understand that our group deputy chair is not here, and we should give her the best. I don't know, David coming?
He's just running a little late.
We do have a quorum. Okay, very good. So then I'd like to call the meeting to order and ask for approval of the minutes of September 12th. Okay, any additions, corrections? If not, all in favor?
Aye.
Very good. Okay, let me lay the groundwork for how I'd like us to proceed. Obviously, people have differences. As you know, all of you, we issued a preliminary report, CMIR, on the proposed merger of Beth Israel Deaconess and Leahy Health Systems. And then consistent with our mandate, that preliminary report was then reviewed by the parties and any other groups, and we did receive a number of comments which we faithfully reviewed and summarized in the forthcoming analysis report, including our comments of our staff. So what I was hoping we would do this morning is to have David and the staff go through very quickly a summary of the main aspects of the merger and the comments that we received in our responses. If you have, as commissioners, any questions about the report, now I hope and I understand all of you had an opportunity to look at it and review it. To the extent that you want to make changes in the wording of the report, you can. Ultimately, the report is the commission's, not the staff. So we will entertain any wording changes. Of course, any wording changes we technically have to vote on because it really becomes, well, you want something doesn't mean others want something. So I'm not looking for any kind of confrontation, but I think we're sort of in a democracy. Then, assuming that the language is okay, we then will, at the end of the report, there are two important referral paragraphs. I would then ask you as commission, but before we do that, as we did the last time, I will give each commissioner an opportunity to make a brief statement about your sense of this proposed merger and what you think about it. After that, we will entertain any changes in the wording of that referral, those referral paragraphs. Again, if you want to change the wording, we have to vote on it. Assuming that at some point either we agree that the referral language is acceptable, or we make changes which we agree are acceptable. We then have to vote on the referral language. Assuming that we get a majority, if not unanimous. We then have to vote on the issuance of, assuming that we want to, because that's what the referral language refers to, issuance of the report to the Attorney General and to the Department of Public Health. And then we have a vote on that. So there were three parts to this, plus your own comments. And again, I welcome any comments you want to make. And this is an important issue, subject for the Commonwealth and for this commission. Everybody comfortable? Okay. I'm going to turn it over to David.
Great.
Welcome.
Good morning, Commissioners. Good morning, everyone. Thank you for being here for this important consideration of a very significant transaction and review, which has been ongoing for quite some time. So we're very pleased to present on the final report and analysis of the parties' response to us. Before we get to that, we have our standard closeout of material change notices since the last board meeting. So we'll ask Megan to quickly go through that and then turn it right over to our Director of Market Performance, Kate Mills, who will lead the discussion on the analysis of the report.
Thank you, David. Since 2013, the HPC has received notice of 94 provider transactions, with clinical affiliations the most frequent, followed by physician affiliations. We currently have one notice under review, the proposed joint venture between Shields and Reliant Medical Group to operate a freestanding ambulatory surgery center west of Boston. Since the last board meeting, we elected not to proceed to a CMIR for 3 transactions. The proposed contracting affiliation between Partners and Cooley Dickinson PHO, the proposed acquisition of Health Express by a subsidiary of South Shore Health System, and the proposed acquisition of Home Health Foundation by Wellforce.
Is there any questions that Commissioners may have on those transactions? Seeing none, I'm going to turn it over to Kate.
Great, so as Chair Altman helpfully summarized, the Commission issued its preliminary report on the proposed merger, Beth Israel System, the Lakey Health System, New England Baptist Hospital, Mount Auburn Hospital, and then Jake's Hospital, as well as the related contracting affiliation with Makaipa on July 15th. The parties responded on August 17th, and the Commission also received a number of comments from other members of the public, all of which are posted to our website. Those included comments from the Massachusetts Association of Health Plans, the Make Healthcare Affordable Coalition, the Greater Boston Interfaith Organization, Lawrence General Hospital, and a number of community members in and around the Gloucester area expressing concerns about us at Middleburg Hospital. Today, we wanted to update you on the careful analysis that we've conducted of the parties' response and updates we are recommending for the final report. As you know, that final report may include referrals to other state agencies like the Massachusetts Attorney General's Office and the Determination of Need program within the Department of Public Health. And then you will be asked to vote not only on the release of the final report, but also separately on any referral to those other state agencies. Finally, just as a reminder on timing, the merger has been on hold during the pendency of our review. Once that final report is issued, the parties will be able to close on the transaction within 30 days.
Just as a point of clarification, actually the referral is not to determination needs to the Commissioner of the Department of Public Health for her consideration to bring to the board.
Thank you. Important clarification. As a quick reminder, the findings of the preliminary report were in brief that the transaction would create a second largest healthcare system in Massachusetts, Beth Israel Lakey Health, nearly equal in size to Partners Healthcare, and that the new system would have enhanced bargaining leverage that would enable it to substantially increase commercial prices. The Commission also identified certain access concerns, particularly given the fact that the parties serve proportionally fewer Medicaid patients than other systems, but highlighted that the parties were important providers of behavioral health services. Finally, we found that the parties were engaged in a robust planning process that could result in initiatives that could improve patient care and enhance access to behavioral health services, but that many of their plans were still in development, meaning that it was difficult for us to assess the scope and likelihood of any such improvements. Chair Altman led a discussion where you commissioners raised a number of questions and concerns that you asked the parties to address in their response to the preliminary report, which we've summarized on this slide. Specifically, commissioners asked for commitments to ensure that price increases and spending impacts would be moderated. For more information about how the merger was different from past mergers, in particular the merger that created Partners Healthcare System, what the merger would enable the parties to do that they aren't already able to do, why the parties would be more attractive to patients once merged, more information on the efficiencies the parties state the merger would allow them to achieve and the financial implications if the merger doesn't go through, commitments to minimize negative impacts on vulnerable patient populations like Medicaid patients and other providers in the market, and more information about how the merger would positively transform care delivery and result in care being delivered in lower cost settings. The next few slides go through the new information provided by the parties on each of these points and other updates in the final report that differ from the preliminary report. And with that, I will turn it over to Sasha Hayes-Rasnam to walk through some of the new information we received about care delivery in particular.
Thank you, Kate. Good morning, commissioners. So the party's response, as you saw, included high-level descriptions of a variety of potential plans that the parties are developing. And amongst those plans were 4 care delivery initiatives that the parties are proposing to enact, for which the new information included a proposed timeline for implementation of 5 years, and some specific goals that the parties expect to achieve for each of the programs within the timeline. The programs are summarized on this slide. I'm happy to discuss any of these and want to call out in particular the proposal to extend behavioral health integration using the collaborative care model to all employed practices of the BILH system within that 5-year timeline. As you can see, the goals also included estimates by the parties of the amount of savings they expect that the programs would achieve as a result of lowering unnecessary utilization for patients. These plans have the potential to result in some savings and to improve the quality of care and access to care for their patients if the parties achieve their goals. The final report, as you've seen, reflects these findings, and monitoring of the parties' progress on these and their other care delivery initiatives will be important if the transaction goes forward. Any questions on any of these initiatives before we move forward? Great. Also contained in the parties' response was a table titled Estimated Annual Efficiency Impacts of the Proposed Transaction. You can see the parties' table reproduced on the left side of this slide under the blue headers. The table combines financial benefits to BILH from revenue increases and expense efficiencies that the parties expect to achieve, with potential savings to the public. For the purpose of clarity, we've separated these into the top part of this table, which is potential savings to the public, and the bottom side of the table, which is potential revenue and efficiencies for BILH. The first line of the table is the HPC's estimate of potential savings to the public if the parties achieved their goals for shifting care, including netting out the impact of patients who would be expected to come from both higher cost and lower cost institutions instead to BILH. Line 4 of the table, which the parties titled Other Savings, is revenue to BILH from these same shifts, along with some additional revenue and efficiency they expect from performance on risk contracts. The second line of the table represents potential savings from the 4 care delivery initiatives we just discussed. It's a total of the numbers that you saw on the prior slide. There are some outstanding questions about whether the parties would achieve exactly these numbers, but as we discussed, there is potential for savings here. The savings estimates I want to note on both lines 1 and 2 are calculated based on the parties' current prices and upon them achieving fully the goals that they have set out. each would be lower if either of those factors change. The third line of the table, cost synergies, is the party's estimate of internal efficiencies they would expect to achieve in certain non-clinical overhead expenses. As we discussed in our presentation on the preliminary report, parties have stated that BILH would use these efficiencies to fund care delivery and integration programs. And this includes funding for the initiatives identified in the second line and on the previous slide. The parties' efficiencies, these efficiencies, as well as the revenue on the fourth line of the table, are part of the parties' financial projections, which show that BILH would be financially successful even without additional price increases. And with that, I'm going to turn it over to Megan Wolf to discuss the potential impacts of the transaction on price and competition, unless there are other questions on this slide.
Any questions?
Thank you, Sasha. The party's response does not include new information or commitments that change the HPC's projected price and spending increases, despite the fact that commissioners asked the parties at the July board meeting for such assurances. The party's response claims that the HPC's projected price impacts are overstated, but do not provide supporting evidence, their own estimates of future price increases, or an alternative model for projecting price increases. The parties continue to state that it is in their best interests to remain lower priced than partners. But as we highlight in the preliminary and final reports, the HPC's projections are conservative, and the parties could receive the projected price increases and still remain lower priced than partners. As you can see on this chart, the small blue and red bars, the projected price increases would only close 29 to 39% of the gap between their current prices and those of partners. The party's response claims that the transaction will increase competition in the healthcare market. To support this point, they cite evidence from other industries where new competitors enter the market. However, the parties to the proposed transaction are already providers in Massachusetts. This is a consolidation of existing competitors, and research has shown that consolidation generally decreases competition and increases prices. The parties focus on the impact of the transaction on partners, but do not address the potential for a destabilizing impact on smaller providers. Commissioners asked the parties to explain how the merger would make the parties more attractive to patients. The parties' response does not provide much on this point, instead making general statements that the transaction would enhance their reputation and that new innovative insurance products can increase volume.
The party's response also touches on a few additional issues that you raised in the last meeting. With regard to Medicaid patients, the parties provided some information in their response about the mix support of affiliated providers with high Medicaid mix, as well as some information about the payer mix of Leahy's behavioral health services. However, the response did not include any prospective commitments to expand Medicaid access. As I'm sure you recall, in the July 18th meeting, we also spent a fair bit of time discussing trends in keeping community-appropriate care at community hospitals. And the commissioners asked that the parties provide more information about how they plan to shift care to lower price settings. While the parties did not provide information directly responsive to that point, they did provide more information about their support of their own community hospitals generally, including volume increases and case mix index increases at those hospitals. With regard to financial performance, the parties did provide updated audited financial statements for FY17, which largely align with the FY17 projections that they had provided prior to the preliminary report, and stated that if the merger didn't go forward, they may have to cut clinical services such as behavioral health. But none of the new information indicates that any of the parties is in immediate danger of closure or changes any of the parties' long-term financial projections. Finally, the parties did provide high-level descriptions of other care delivery initiatives beyond those that Sasha just went over, But for those other initiatives, they did not provide enough information or detail that would allow us to assess the impact of those plans on costs, quality, and access. In addition to the final report incorporating information from the parties as described on the previous slide, the final report also incorporates new years of data in many of the analyses, as well as minor technical updates. Updated analyses include the ones that you see listed here, but all updated figures are highly consistent with those in the preliminary report. The main thing to note is that the updates do slightly change the range, in particular for the projected price increases, as highlighted in the next slide, which goes over the key findings in the final report. As detailed in the final report, the HPC finds that the proposed transaction would significantly increase BILH's bargaining leverage and ability to obtain higher prices from commercial payers. We project that increased prices for inpatient, outpatient, and adult primary care services could increase total healthcare spending by $128.4 million to $170.8 million annually, with additional impacts likely for other healthcare services. While the parties have put forth plans to shift care to lower cost settings and to improve care delivery, as we just discussed, and those could result in savings. Those savings are not sufficient to offset projected price increases. And finally, the parties have projected significant enhanced revenue to their system and internal savings that would allow them to be financially successful without price increases, but have not offered any commitments to date to constrain future price increases. As you see here for quality and access, those initiatives for which the parties have provided more detailed information do suggest a potential for improving quality and expanding access. However, the parties have not provided any commitments to expand Medicaid access to date, and many of their plans are still too early in development for us to assess the likelihood or scope of any enhancement to quality or access. And I'll pause here for any questions about our findings and the parties' response before moving on to talk about next steps.
Okay, any questions or comments about what Kate has indicated so far? Sure, please.
Among the responses from the parties was an attack on the willingness to pay model, saying that it was empirically didn't play out. We actually looked at markets in which the community made predictions. Could you say a little more about how staff heard that?
Sure. So we attempted to replicate the parties' analysis, and it's actually in the appendix to this. Sorry, many slides. Aha. So we attempted to replicate the parties' analysis. So the parties analyzed some of their past transactions, and noting that in our preliminary report, we had stated that we didn't see significant price increases after their past transactions, had made a claim that willingness to pay predicted price increases, and because we had found none in those circumstances, that it threw the overall model into question. We attempted to replicate their analyses, as you see here. So the very first table shows what the parties put forth on the left side. So you see, for example, Leahy's acquisition of Northeast. They estimated a willingness to pay increase of 5.2%. We were able to replicate that only by making a number of methodological errors. And so, for example, treating Addison Gilbert and Beverly Hospital as independent and competing providers prior to the transaction rather than part of the same system, Northeast. We found a number of other tweaks. They used a slightly different model. Again, they took into account some different information than we know is actually factually the case. with some of the other transactions. For example, Cambridge Health Alliance, prior to affiliating with BIDCO, had contracted through partners. That too appears not to have been incorporated into their model. When we actually ran these with our own model, you see the willingness to pay increases on the far right that we found for these transactions. I'll note that the research literature points to 6% willingness to pay increases as kind of a key threshold, where below that there's just more of a chance that there won't actually be a significant increase in price, and above that there's a much higher likelihood of a significant increase in price. So for all of these past transactions, you see, using our methodology, we found that the willingness to pay increase was under that 6% threshold. However, for the BILH transaction, which the parties did not provide a willingness to pay for, we found an increase in willingness to pay of 10.8%. This is inpatient only. I'll note that we found similar ranges of willingness to pay increases on the outpatient and primary care side as well. When you apply those changes to price, as you see on the bottom slide, you see that for the past transactions, Leahy's acquisition of Northeast, Leahy's acquisition of Winchester, and BIDCO's affiliations with CHA, NHS, and Lawrence General, all of those price increases are much smaller than what the parties put forward, and all of them, as I said, are below that 6% threshold that the research literature has indicated is really where you see kind of the turning point where you can really predict with some reliability that a transaction is likely to result in significant price increases.
Okay.
Yes.
Again, just to remind the group, it's quite common in economic research. We're not talking about straight lines. You know, we start with 0, and if you go up to 10 to a point, you get it. So what Kate is saying and what the literature indicates is that you need to have a significant threshold for any model to kick like willingness to pay really kicks in. And it's not unreasonable for it to be 8 to 10%. Good try.
Precisely.
Any other questions or comments? Okay. So before we discuss the referral language, I'd like to give each commissioner the opportunity of making any statement. And Chris, since we put you last the first time, I'm going to give you the opportunity to start out.
Pleasant surprise.
You know, just keep you off balance.
So this is hard work, trying to figure this stuff out. Our charge is to try to opine on anything that's going to affect cost and quality. And I think by any standard, the quality of care represented by petitioners is extraordinary. We're all lucky to have great care here in Massachusetts, and hopefully get better. But it seems like consolidation, from my perspective, as it's presented here, is part of the old playbook that has played out in Massachusetts and around the country. And it is a playbook to get bigger and to gain leverage in order to obtain higher prices from insurers. And so I'm going to suggest that we refer this, but I think with some strong language about the need for a new playbook. There are examples around the country where premiums are going down, where providers are lowering prices in order to attract consumers, in order to attract employers, to bulk up that way. Narrow networks are increasingly popular. And by doing that, these systems are taking financial risk along with clinical risk. We're all schooled now in value-based care and moving away from, I think, profligate fee-for-service models and moving toward kind of a breakup of the duopoly between insurers and big systems. And I think disintermediating insurers was something I expected from the petitioners, a real serious plan to take on innovative insurance, risk-bearing models. And in addition, I think that Kate just went through the numbers, the suggested systems integrations efficiencies. They amount to about 1% of revenue. And in the private sector, the shareholders would rebel at 1%. Wouldn't happen. So I think we are, we can do better in Massachusetts. Stuart, you said last time, I think we need to do better, we need to push harder. And I wish that we had more detail from the petitioners. And I'll stop with that.
All right, I appreciate that. Elizabeth?
First, I want to thank the HPC team for their outstanding work. I know this was.
You may want to get closer.
Oh, thank you. I know this was a huge amount of work, and we appreciate it. Pete, Megan, Sasha, thank you. And thank you to the parties. I know this was a long and onerous process. Their cooperation made it possible. So I think a lot of encouraging things came out of the parties' responses, including learning more detail about the innovative ways they're going to deliver care, particularly as behavioral health. And we also see encouraging things from your analysis about past transactions and how there were more community appropriate discharges with corporate affiliations, prices didn't increase. So there are encouraging data points. But I do think, consistent with what you presented, the willingness to pay model, while limited and conservative in some instances, is the best information we have about prices. And the data we have is concerning. And we didn't get a lot from the parties as to how that will be limited in their response. So all that said, I think this is an opportunity to transform care in Massachusetts, to inject more competition into the market, but there needs to be guardrails on that, and that's appropriate. So I think that referral is appropriate in this situation.
Thank you. Ron?
Thank you. Like Elizabeth, I want to thank the HPC for all the work they've done, and I know how difficult it is for the folks trying to put this deal together, try to get this thing done. It's not easy. And trying to work with all the different political organizations as well. But at the same time, I think we have an opportunity as a state to look at a merger that can actually be helpful and can actually improve quality, also restrain price increases, and actually move towards more innovation. And the key is, yes, we need to refer the report, but I think we need to work together in terms of how can we most effectively manage price increases, provide the quality care for everybody in the state so that everybody has access, and then to focus on innovation as well. I think we can do this, and it can be positive, but looking back at the history based on the work that's been done, we can't do this as it has been done historically in the country. We really need to find a way to manage this so that it truly does become more competitive. Thank you.
Jim?
Yeah, thank you. And again, thanks to the staff. Clearly, always do an amazing job. We're going to move from one controversial issue to another one next week, so we look forward to continuing the controversies. I think, just to join the chorus, I mean, I think my focus here and thinking about this transaction is one about where the patient's coming from and where they, what system they're coming from and into. One of the things that I continue to look at in reviewing the reports is not just the impact of where the patients are coming from the lower cost, high value community hospitals in the service area. And when you look at the numbers of where the estimates are, clearly the numbers are lower for those providers, the community providers in the area, but I think the impact will be significant for them, particularly given their patient population and payer mix when you take away, 9% or 5% of that patient population of their private insurance, it's going to be implications for that. I think it's important that we remember that and focus on that. It relates to my other point here, which is the transparency going forward. If this transaction is approved, finally approved, I do support referral with conditions, and I think that's an important part of the conversation. But I think an important piece is the transparency around all the goals that have been stated, which seem great, and what is the implications of those, and how do we analyze those in real time and not over a long period of time and look back, but as things are happening and evolving. I think there could be really big implications for the community providers in the area and for the patient population that they take care of. So I think that's an important piece. So where the patient's coming from, what's the impacts on the lower cost high value providers, which we're trying to drive care to, and how do we analyze and have a transparent process as this unfolds. Additionally, I think clearly the numbers around the willingness to play model and the potential price increases are of concern. Clearly, I think that looking back and thinking about how do we try to rein in those increases and how do we keep those under control, I think is really important. I think it's also really important when we look at this too that not all providers in the system are equal. When we talk about price and disparities and rate disparities, there's rate disparities within that system as well. And so when we're looking at any additional conditions or guardrails that's suggested, I think we really need to take into consideration, look at all the individual hospitals in that system around where they're at financially and the rates that they get paid. So when we look at price disparities, we have to look within the system and if that's revenue sharing or other ways to figure out how the community hospitals in that system are supported through the process. That is critically important. And also as we look at or think about ways to cap the price increases, that we take in consideration both the affiliated and non-affiliated hospitals in that system to ensure that they're not negatively impacted. We want to make sure that they have the resources to provide the care in the community settings that we all want to push patient population to. So I think we got to take that in consideration. And then clearly, the issues around the patient population within this system and the Medicaid population in particular. I think it's really important to think about what that means and how this system and as a state we're delivering care to this population. I think we're doing a lot of great work at the Health and Human Services Office. Thank you, Secretary. But that I also describe the fact that we need to make sure there's more Medicaid patients or payers in the system. I think we need to make sure the system is helping support the care that's being delivered to that patient population and working with providers that are already doing so in very effective ways and that they are invested in that. And I think there's ways in which we can do that, and I hope that we take that into consideration and again do support the referral to the Attorney General's office and look forward to further conversations to ensure that we try to support and push forward the positive aspects of this, but make sure that other things are in place to mitigate the negatives.
Thank you. Rick?
Great, thanks, Mr. Chairman. I also again want to thank, as my colleagues did, the staff for the great work that they've done on this complicated undertaking. When this first came before us, I was very interested in understanding what the impact of this would be, because for many employers in Massachusetts, the current delivery system is just not working. Small to medium-sized employers continue to see, big rate increases, even though we know that total medical spending has actually been below the benchmark, but it hasn't translated into better premiums for most employers. I think we're very fortunate that we have these high-quality, reasonably priced providers that have come together to propose to us a new system. My thinking is that although I think the HPC report raised very legitimate concerns about the potential impact on prices and some of the access issues, particularly around mass health patients, it seems to me those are things that could be adjusted with reasonable conditions, which is what I think many of my colleagues have suggested. So I support the recommendation to refer this to the Attorney General and look forward to continue to work on this to kind of come up with those guardrails or those conditions that will address the legitimate concerns that the staff found, but will provide a reasonable alternative for the citizens and employers of Massachusetts.
Secretary?
Thank you, Mr. Chairman. So from the outset, let me say I support the staff recommendations of the referrals to the Commissioner of the Department of Public Health and to the Attorney General's office, in part because of the size and scope of this proposed merger transaction, as well as that there were several areas that the parties were not responsive to, particularly in assuring that the increased market share would not be used to increase prices. As we commissioners and the Attorney General's office and the Department of Public Health think about and recommend cost controls, we need to also be certain to make distinctions between the corporate affiliates and the contracting affiliates and not treat them as the same and to ensure that there's disparate impact on the contracting affiliates. So as I said, I concur with the staff recommendations. Depending on the vote of the board, I will formally ask the Commissioner of Public Health to bring to the Public Health Council to revisit the DON that was conditionally approved in April for additional and/or modifications to the conditions that were approved last April, based upon information that's contained in the CMIR. The Public Health Council will take this up on October 10th at its next Public Health Council meeting. In revisiting the preliminary DON and the conditions, based on this CMIR report, issues such as access, payer mix, behavioral health, and cost controls, and care, ensuring care at the right level, are some of the areas that the Department of Public Health staff will be looking at to revisit. These areas are important not only to be maintained, but improved upon at both a systems and individual provider level. The tools that can be utilized by the Department of Public Health in recommendations to the DON and the Public Health Council include extending the conditions beyond 5 years, reviewing and approving any future DON projects for any of the facilities to come before them would be based on satisfying the conditions of this DON, that has been approved, and obviously failure to satisfy the conditions of the DON could result ultimately in proposing revocation of this DON. And also the Department of Public Health and OHHS will discuss with the Health Policy Commission the opportunity to rather in the future do another CMIR on this project or have it as a result of cross-trend hearings in a few years. Thank you, Mr. Chairman.
Okay, you get to go, Marty.
Thanks. I think it's important to, at the outset, to remember that the breadth and scope of this merger was unlike anything that I think this commission has seen in its history. So I too want to acknowledge the work of Kate Mills and her staff, who really did admirable work in bringing together this both the draft report and the final report. I think the findings are clear in the report. We can debate some of the actual numbers, but the conclusions related to costs, I think, speak for themselves. I was heartened to see that the parties gave careful consideration to the behavioral health implications contained in this merger. And I think there are clear opportunities to both replicate and expand the robust behavioral health services that both these entities currently provide and to expand them to the rest of their network. So gratified to see that. While I too am comfortable with the final report and the recommendations for referral to the Attorney General and the Commissioner of Public Health, I do think regardless of this merger, there remains real concern about the long-term viability of our community hospitals. A merger into large systems, as Dr. Kreider pointed out, shouldn't be the only vehicle available to these healthcare institutions as they seek to remain important parts of the Commonwealth's healthcare system. I noted that in the minutes of the recent HPC Advisory Committee, this issue was also brought up again about the future of community hospitals and In the minutes, our executive director, David Selt, spoke about the need to possibly update the commission's work in looking at the community hospital system, and I would certainly endorse that as we go forward. But again, I'm comfortable with the report and the recommendations.
Thank you. David?
Thank you, Mr. Chairman. Let me just make a few comments. One is to echo my fellow commissioners in thanking the staff and parties. I also just want to note, one of the reasons for this process, Mr. Chairman, was that the Commonwealth wished to shed some light on what had been very opaque processes associated with consolidation in medical care. And we now have, for this particular transaction, over 200 pages between what our staff has put together and what the parties have put together, allowing the people of Massachusetts to get some insight into what's going on in Judge. And so whichever way this turns out, that's a clear victory for the people of the Commonwealth and their ability to know about what's going on. Like many commissioners, I just want to echo a point that Marty Cohen made, which is that this is the most difficult case we have ever had. And it's difficult in the sense that the range of possible outcomes of this is greater than the range of the possible outcomes of any other transaction that we have had. So it could be a transaction that is absolutely wonderful for the Commonwealth by stirring competition and lowering costs and bringing fresh energy into healthcare. And it could be a transaction that is terrible for the Commonwealth by resulting in not one system with high prices and then a number of other systems struggling, but in two systems with high prices and then everyone else struggling even more or going out of business more. So the range of the potential outcomes here is far greater than anything we've dealt with. Where that inclines me is where it inclines most of the commissioners, I think, which is to say that the way that this can happen can't just be have a one-time decision that then gets locked in forever. That is either yes or no, and leave it alone. But rather that there has to be some process by which, if and when this goes through, there's regular continuous monitoring and corrections to be made in what's going on, so that if things are going in the poor direction, that gets fixed immediately. And if they're going in the good direction, then that gets encouraged and celebrated, and that it continues to happen. So I see where this is going as a referral in part so that we can set up a monitoring system that ensures on an ongoing basis that this meets the needs of the Commonwealth. And those needs, I just want to say, I think are threefold, and I just want to lay them out because I think they're how I would personally judge anything going forward. Number one, there absolutely must be savings for consumers. So that is the goal here. The goal here is to make medical care be better and less expensive for the consumers. It is not to protect any institution or to harm any institution. It is to make the world better for consumers of medical care. Number two, that the market must be more competitive, not less competitive. That it must have greater opportunity for people to get what they want and to get it where they need it and to be able to afford it, and not less, not locking people in and denying people access to what it is that they need. And then number three, that because of this, there can be no harm on other institutions that are less fortunate, particularly those less fortunate institutions that are serving our neediest members of the population. So those organizations that are taking care of people with very complicated needs who are not reimbursed well, who have enormous difficulties figuring out how to survive and make sense in our healthcare system, those institutions and those people have to be benefited by this. So those are the three criteria that I look for. What I hope, just to come back, is that what's put in place is a very rigorous process to make sure that that is what happens, and that if that is not happening, the Commonwealth have the ability to do something right away, ongoing, real-time basis to make sure that this works out, so that this is to the betterment of us all, not to our detriment.
Thanks, Stuart. I'm reminded of the comment, everything important has been said, but not everybody has said it. So I echo a lot of what's been said. First, kudos to the staff again. This is immensely hard work and so well done. I'm just really proud of you all and thank you for the support you've given. And to the parties, you've been very dignified and engaged seriously. And I just want to say, my respect for the institutions involved could not be higher. We're blessed to have these organizations here, as Chris said. Nothing I'm going to say mitigates my enormous regard for these organizations. But the question is, does the merger serve the Commonwealth in the terms that David recited? The answer is no, not yet. We have not received a picture that shows us that the Commonwealth as a whole will benefit from this merger. There's hope, and there's certainly promise these organizations are capable of delivering the kind of transformations that we want, but they have not yet promised or guaranteed that. I do not know if anyone has the authority to stop this merger, in fact, but I think what several commissioners have said about working with the parties to try to come to a good solution is the way to go. I support the referral. I want to make two general comments. First, on the parties' response to the report, and second, on my concerns. So the parts of the response I was looking at are the ones that I'm keeping my eye on, much as David recited. The first is the integrity of the safety net in Massachusetts. I think there is a threat to our ability to help the neediest in this state. I think it's much bigger than this merger. I think we really need to look hard at the safety net as a whole, but the parties have a duty, they do have a share in this. And right now, they have not yet reassured us that they will protect the interests of Medicaid low-income people. It is not in their financial interest to do so. You lose money when you do that, and these parties have not yet shown that they're willing to take that hit. Maybe they will not be able to, but I would very much hope that in further conversations upon referral, we will get a much stronger picture of how poor people will be protected. The second is cost. It's a care redesign. One of the great promises of the organizations is that we get really new models of care, both under the value-based payment that Chris was referring to, but overall. I know that that's in the thinking. I think there are working parties underway. We have not yet seen from these organizations a picture of the really transformational care that could emerge from this merger. We've seen 4 proposed programs. That's not transformation. And I totally support the expansion of behavioral health care, but that is not by any means a large enough answer to the questions of how we help overall integrated care in the state to proceed. I'd look for more of that. It's not even near as bold as what we need. Nor is it clear to me, given what they do promise to do, that they need the merger to do it. So there's a gap. The third is the protection of the affiliates. I am not convinced, based on the record, that Lawrence and Cambridge have been really protected in their affiliate relationship with the parties to date. Advocacy for the interests of these key facilities to me is an index of our commitment to maintaining community-based access. They're not alone, but they're really important. I'd add to those community health centers that need to be supported. So again, I'd be looking for much stronger language on the parties about how they will make sure that these key institutions are protected. The idea of not subjecting them to the same cost caps as this entity should be subjected to, I think it's well worth considering. And second, some form of promise that the merged entity won't be predatory on the service areas for those key institutions. They could overwhelm them easily. Fourth, there are no promises at all on pricing in the response. Pricing will go up. There's no question in my mind. The parties propose savings, as all mergers do. Those savings, by the way, are rarely really realized in mergers. But if they are, we need guarantees that those savings get transferred to the consumer. And there's no such guarantee. So in summary, I do support referral, but here's what I would like the AG to be looking at. First, costs are going to go up. They're going to go up substantially. All the evidence favors that I see favors that. We need a form of restraint. We need some resistance to the inevitable temptation to take advantage of this heft to raise prices in a market that's distorted by one dominant player. We need to know the competition will work, as David said. There's a lot of betting on that. I don't know. I don't know what responses from partners will be. I don't know what their responses to partners' responses will be, but we need to know more than we do. I must say I'm taking a breath on this. It's mitigated by the success we've had so far at mitigating price increases. We should be really proud of that. This Commonwealth has worked hard and successfully for the other states. So we bought ourselves a little time. The second is the safety net and community resources are in jeopardy in this merger. I'm convinced of it. Medicaid could be heard, and Lawrence and Cambridge could be heard, and I don't know more about the CHCs, but we need to know more about them. And I'd like to understand, I'd like the AG to understand how they're interested in protected. My third belief is good faith is not enough. You could not have parties in better faith than these. They're wonderful organizations. They've been terrific players in our community, but the temptations here are enormous. And so I'm going to be interested in enforceability, which is the contingencies that the Secretary was referring to. We need good promises and consequences for not keeping the promises. The last point is similar to David's. We've got to learn from this, both by monitoring in very close cycles, maybe much more frequent reviews than the Commission has generally done. But what is really happening? What new adjustments do we have to make because of what happens? And I think there should be monitoring agreements here that are very strong and very clear. And we should be players in that along with GIA and department. Then in the longer run, there's a big learning cycle going on here. What happens when markets consolidate this way? We tried to find out from other markets. We couldn't find out. Let's be a source of information for others that are going to struggle with this as we evaluate. So Stuart, I support the referral. Thank you for the time.
Thank you all. I mean, not surprisingly, your comments are right on, and I really appreciate it. I also appreciated the fact that in the response of the parties, they spelt my name right several times, and got a lot of publicity. I was a little taken back by the distortion of my comments, but so give me the opportunity to say them again. And that is, sure, our estimates are estimates. I've done as much research as I could in terms of different models, and by far, the willingness to pay model is the best in the country, if not in the world. Been cited a number of times in judicial findings, and as far as I know in the literature, and I think David would support me, it's been supported by it. But it is estimates, and I appreciate your putting in the report when you put in the context of the gap between where we are today and the potential for this group to raise their prices much closer to our leading biggest institution. It's only, our highest are only at 39% of the difference. And if they were to go up to 75, they could still say they're less expensive, but then the gap, the amount of money that it costs the Commonwealth doubles. So, yes, I use the word hypothetical to indicate that it is an estimate. But don't get me wrong, and I think I've heard from almost everyone here. If anything, it's on the conservative side. And quite frankly, and I would say this, you're sitting in the front, I was really hoping that your responses would have been much more aimed at, the kind of comments that most of the commissioners articulated the last time. We were and still are looking for a win-win, I think, what everybody said and what Don said. What I rejected then and would reject now, I know many of my colleagues around the country have a very antitrust lawyers and antitrust economists have a very strong view that the only way to mitigate the negatives is to say no. That any attempt on the part of government, attorney general, the Justice Department, to mitigate just doesn't work. That ultimately the system breaks down. And so I've been getting comments from others that said, just say no. And I said then, and I say now, I reject that in the comment. I think for the better, are different in the sense that we do have mechanisms here. The Policy Commission Chair, the Secretary, and the Public Health Council are very aggressive Attorney General's office to put in place meaningful and enforceable restrictions that allow the Commonwealth to see a win-win situation. So I fully support the issuance of this report and the report itself in terms of substance. And I urge the parties, and I'm so pleased, Madam Secretary, for your comments. And I know the Attorney General and her staff will do the right things, and you've heard from our commissioners about what the right thing should look like. You know, again, I would support what Don just said. I have the utmost respect and admiration for the parties involved in this. And I know you have the opportunity and that your heart is right and that you will do the right thing. But, you know, but as I said, I would have liked to have seen it in your response. For whatever reason, you chose not to do it, but you got another opportunity as we issue this report to the respective bodies. And I still look forward to the fact that this will wind up being a win-win situation. So again, I want to thank you, Kate, and Megan, and Sasha, and you too, David, for really a job. So with that, unless anybody has any comments, we're now going to go to the part where we go over the language of what the recommendation.
Commissioners, it is exactly the same as what's displayed. We just changed the formatting a little bit on the displayed presentation. I think it's slide 23 in your slide decks.
You know, if you don't mind, David,
Yep.
I know it'll take a little read. You want me to read?
No, I'll read it.
You won't?
So the motion, well, I won't read the motion. Based on these findings, the HPC concludes that the transaction warrants further review and refers this report to the Attorney General to assess whether there are enforceable steps that the parties may take to mitigate concerns about the potential for significant price increases and maximize the likelihood that BILH will enhance access to high-quality care, particularly for underserved populations. The HPC additionally recommends that the Commissioner of the Department of Public Health and the Public Health Council reconsider the approval with conditions of the determination of need application and assess the need for additional or revised conditions to ensure that the applicable determination of need factors are met.
Okay. Are there any changes, additions, corrections that anybody wants to propose? First of all, is there a motion to approve this? Okay, second? Okay, now, again, are there any additions, corrections, or changes that anybody wants to make in this word? If not, we're going to vote. Having heard none, all in favor of the motion? Aye. Let's go around the room. Chris? Aye.
Aye.
Aye. Aye. Aye. Aye. Aye. Unanimous. Very good. Second. Okay, now, now we move to the.
So this is the final vote authorizing the issuance of the final report
Now-
as amended.
Again, let's be clear, what we're talking now about, we've approved the report, but the law requires us to issue that. So as it says in the motion, that pursuant to section 13 of chapter 60 of the Massachusetts General Law, the commission hereby authorizes the issuance of the attached final report on the cost and market impact review of the proposed official lay. Second? Any changes or comments? All in favor? Again, Chris?
Aye.
It is unanimous. Again, thank you all. And now we turn it over to the forces, but we will be watching. Okay. So we're now going to take a short break. Is there anything
We
we
have
want
to
to
close
do
the
first?
meeting.
Yeah, we're going to move into an executive session. And to do that, we do require a roll call vote to move into executive session. The purpose of the executive session is to discuss confidential named providers and payers through the performance improvement plan list. And for that discussion, we can't go into executive session. So I think that there would be a motion to go into executive session is.
Now we have to do a roll call. All right, I'm gonna go the other way around. Okay, so Don? All right, Martin? Okay, David? So he's not here, Tim? Chris? Okay, Rick? Ron? Secretary? Okay. Elizabeth? I'm not missing you. All right, aye. Okay, so we're gonna take a short break and then we'll do executive session.
How are you? Good, how are you?